Good afternoon, everyone, and welcome to the spring edition of our Behind the Scenes lecture series. I'm Louise Aspin. I'm the Senior Vice President and Chief Development Officer of Toronto General and Western Hospital Foundation, and it's my great pleasure to welcome you all here today for this interesting discussion. Whether this is your first time here or if you've been included in these talks before, this afternoon's event is our way of saying thank you to all of you, our donors, for your support. Our doctors, researchers, and scientists would not be able to pioneer new discoveries without your support. And at these behind-the-scenes lectures, hopefully give you a bit of a snapshot of the work that's happening here. Today we're featuring a panel discussion on a subject that invites a great deal of discussion, thought, and concern: the specialty of palliative care. We've asked Canada's leading experts in the field to talk with us today about this expanding area of medical specialty. And we're incredibly fortunate that all of these experts work right here at the University Health Network. They'll be introduced in a few moments by our own Dr. Michael Baker. Dr. Baker is our former physician-in-chief and a professor of medicine at the University of Toronto. A leading medical researcher, Dr. Baker's work to further our understanding of general internal medicine, blood disorders, and improving healthcare delivery in Canada. For his contributions to healthcare, he was appointed a member of the Order of Canada and an officer of the Order of Ontario. Please welcome Dr. Michael Baker.
Thank you, Louise. Welcome, everybody. Are you going to meet Warren Lewin soon? I'll make a little more formal 10-second introduction. Don't get excited, Warren. But he was telling me that he did some of his training. I was actually on the faculty at Mount Sinai Hospital in New York recently, the big ivory and gold and brass tower on Fifth Avenue, training in leading palliative care in that institution, participating. When I was a resident at Mount Sinai Hospital, New York, palliative medicine didn't exist, so there was no training program and there was no care. That was a few decades ago, I admit. An interesting beginning to palliative medicine at UHN occurred when I was just starting out as physician-in-chief over 25 years ago, sitting in my office in the old Bell Wing that people like Vitas Miscaviges will remember, and there was a knock on the door at 6 or 7 o'clock in the evening, and a man who was very clearly upset came in, sat down, and said, "Are you the chief?" I said, "Yes." He said, "We need to talk. Sadly, my wife has just died of her cancer, and she received terrible end-of-life care from her doctors." And as I'm thinking to myself, I wonder what my lawyer's telephone number is, because this is not going well. And he then said, "So we need to do something about it, and I would like to make a donation to start funding appropriate palliative care at this hospital." The rest is history, and the late Mr. Barry Rose, whose family is sitting here with me, donated, and with his family, a great deal of infrastructure funding and funding for doctors, fellows, nurses, and has helped us reach the state we are in today that you will hear all about. So palliative, and palliative care has been a journey for doctors like myself who didn't begin with understanding the importance of the field, because we were focused on fixing what we could fix, curing what we could cure, because that was how we were focused and that's how we were trained. We have all come to need to understand what we can do and what we can offer for patients who we can't cure and we can't fix. And we've come to understand that we can help quality of life, we can help alleviate pain and anxiety, and we can help families, patients, and their caregivers with resources and reassurance. And we're going to be talking about that today. Our panel experts are leaders in the field, as Louise has said. I'm going to introduce the panel members, have them come up and join me. I'm going to ask the first few questions to get the ball rolling, but this is going to be an audience participation as well. If there are no questions, we will finish in about 10 minutes and we can all go home. and we'll finally be able to get some other work done. So think of some questions. I might even point to people and say, do you have a question? So be careful, don't fall asleep. In no particular order, because my notes say this, I'd first like to ask Dr. Ebru to come up to the podium. She's the site leader for palliative care in Toronto, and I should say we have 3 experts, and we've got one from London, England, one from McGill in Montreal, and one from New York and Boston at Harvard and Mount Sinai. So we are doing really well in a brain gain in our wonderful institution. First, I'm going to ask Ebru to come up. She's the one from London. Come on up and take a seat. Next, I'd like to ask Camilla Zimmermann, who's head of the Division of Palliative Care at UHN and at U of T, and holds the Rose Family Chair in Palliative Medicine and Supportive Care. She's our import from McGill. Camilla. And the previously mentioned Warren Lewis, who was originally from Toronto, trained in Ottawa, then did a training at Harvard, at the Mass General, and then on staff at Mount Sinai, New York. Warren Lewin. So first of all, the house rules. These people know so much, you have to just watch them a little bit. So I'm going to ask you questions, but please keep your answers to less than 25 minutes each answer. Otherwise, these people will doze off and there will be no knowledge transfer. Oh yeah, my note said 2 minutes. Sorry, I thought that was 25 minutes. So just going from your left to right, I'm going to ask you this tough question is, why did you get into this field? What attracted you to palliative care in the first place, Dr. Kaya?
So when I was a young resident trying to think about what to do with my life as I was growing up, I really couldn't figure it out, and I stumbled across palliative care by accident. And what I loved about palliative care and why I ended up staying in it was the fact that it kind of provided this holistic care of patients, the whole person care, where unlike all the other specialties of medicine that I had rotated through as a resident, I wasn't focused just on one organ, like not just on the kidneys or just on the heart, but really the whole person, and how this person's illness affected them as a person, but also in the context of their family, their friends, their life, their work, the whole person at the most human level. And the fact that it's so patient-centered, where we do our best to focus on what each and every patient needs rather than our own agenda, or we try to as much as possible. And I love that about palliative medicine, and that's really what keeps me doing that work day in, day out.
Thank you. I'm going to have the same question go across the panel here. Camilla?
So, as Michael was saying, I went to McGill, and I went there from Vancouver, actually, originally for my undergrad, and then also went there for medical school. And when I was in my first year of medical school, I heard a lecture by Dr. Balfour-Mount. And I don't know how many of you know maybe a show of hands who knows who Dr. Balfour-Mount is? So a few people do. So Dr. Balfour-Mount is the father of palliative care. He actually made up the term palliative care. But none of us in med school had ever heard of Dr. Balfour-Mount or heard of palliative care. But there was something about the way he lectured and the passion with which he lectured that really spoke to me, and there was actually a few of us in our medical school class who went into palliative care ultimately because of the influence of this lecture. And one of the things he spoke about was the concept of total pain. So when you have an illness, it's not just, you don't just hurt physically, but as Ebru was saying, you also have psychological pain, you have social pain, and that your whole family is really affected by this illness, and you have existential pain because you're looking for meaning in life and how this all came to be, and broader questions sort of come to you when you have a serious illness. So again, dealing with the whole person and having sort of the distant mentorship, I would say, for many years now of Dr. Mount has has led me through to being where I am today.
Thank you, Camilla. And Warren, always hard to be third in row, but I'm going to ask you the same question anyhow.
Okay, can people hear me, or should I hold the microphone up too? Hold it up, okay. Is this better? Okay, so just to piggyback on what you both have said, so I was fortunate enough in medical school to be exposed to palliative care, which not all medical students have that opportunity to do. And it was the first time in medical training I saw the family be considered part of the patient and family was the same. And I really liked how we not only saw a person in front of us, but them in their context of their family and their surroundings. And palliative care is a team-based practice in medicine, and I liked interacting with the team to get people what they needed. And then on a personal note, my grandfather was admitted to a hospital with pneumonia, and he had a lung specialist as his attending physician. And during that admission, he found out he had metastatic pancreatic cancer. And I had already been exposed to palliative care in Toronto. He was living in Texas. And I asked for a palliative care consult, and the answer was, we don't have palliative care in our hospital, but we can get him the help he needs in the community. And people were fumbling with their words. His confusion that he had, some delirium, was really suboptimally managed, and our family was really struggling. And so on a personal note, I thought, not only is this really a good fit for me in medicine, but I'd like to be a leader in this field so I can work towards building capacity so that everyone, no matter where they are, has access to this needed type of care.
Thank you, Warren. Thanks for sharing that personal story as well. Ebru, back to you. Tell us about education in the field. How did we and how are we building a cadre of experts in various professions in palliative care going forward? What's our educational strategy or framework?
Sure. I don't know. No. Sorry. So palliative medicine became a subspecialty about a few years ago, and that led to the development of palliative medicine residency programs in Canada for the first time. And we right now have 5 programs across Canada.
Can't hear? Yeah.
Oh, I'm so sorry. Okay, I'll start again. So with palliative medicine becoming a subspecialty, we've had 5 residency programs that have started to teach palliative medicine to residents for our future doctors in 5 universities in Canada. And we have the biggest program here in University of Toronto, and I'm the program director for the program that we have here in Toronto. And you'll laugh when I say it's the biggest program because we have 2 residents, funding for 2 residents each year, while the other 4 programs have 1 each. So we have 6 positions for the whole of Canada. In addition to that, though, the good part is through the really incredibly generous donations of our Rose family, we've managed to set up some fellowship programs in palliative medicine at University of Toronto as well. We have a research fellowship program that Dr. Zimmermann is the director for. We also have a clinical fellowship program, so doctors who have completed their training in whatever specialty that they have can come back to university to train in palliative medicine at our university at Toronto, and we teach them palliative medicine skills. And we have people applying from all over the world. And it's so competitive now that we have many more people applying than we have positions for, but we have people from Mexico, from Israel, from Thailand, and from Australia as well. So we have some aspects of teaching that doesn't exist in other parts of the world, which allows us to draw these amazing people to our university to teach them.
Warren, you get the last one, which is given some of the issues and the myths and this whole business of not just being about the very, very end of the last few hours of life with a tearful family, how do you broach the subject of palliative care when you're going to a general medicine floor and they've asked you to how do you even start the conversation?
With the team or with the family?
Well, with the family and I guess both. But I was thinking of with the patient and with the family, how do you introduce palliative care without hanging the black crepe and making this, like you're the Grim Reaper coming in
Yes.
to make final arrangements, like, how does
Sure.
that conversation go?
So I think we're probably the only medical specialty that has to define what we do when we walk into a room. So when your cardiologist walks into a room, they say, I'm the heart doctor, I'm the lung doctor, I'm the geriatrician. But if you walk in and say, I'm the palliative care doctor, I think people get anxious and they're scared and they stop listening. And so the first thing that I always do is I show my badge, I introduce myself by name, and I say, can I spend 1 or 2 minutes telling you what I do? And I give the definition that Camilla just said, real brief one-liner. I focus on improving your quality of life in the following 2 ways. This is what palliative care does, and that's what I do. I've very rarely had someone kick me out of the room after I give them the definition of what we do. So I start with the definition, and then I say, how can I help? And I let them open up and talk to me about what's on their mind. And I think one of the easiest things to do is ask about a symptom, because that's really low-hanging fruit that we can help with. And when people are fearful about what's happening, we can't really have deep conversations when they're sitting there with pain, when they're sitting there with anxiety or shortness of breath. And so the first thing I'll do is ask them how I can help them feel better. Then we'll develop a plan to help them feel better, and then start talking about what really matters to them and get them what they need.
Fabulous, thank you. I have lots of more questions that I can ask, but I think that at this point I'd like to ask those of you in the audience to ask any questions. We got lots and lots of hands up, which is great. I'm just going to sweep across the room. Let's start with this person here. We have a microphone coming around.
Hi, Dr. Baker.
Hi.
I'd like to know, how do you see palliative care helping patients with moderate to severe dementia or Alzheimer's?
That's a fabulous question. Who would like to try that one? Warren?
Sure, yeah, that's an excellent question. They actually say in the US that dementia is going to bankrupt the healthcare system unless we have a change. It's one of the #1 reasons why we get consulted at the Toronto Western Hospital to see patients. I assume it might be similar elsewhere. So I think the key really is training every doctor, nurse, social worker, every clinician that is not a palliative care doctor or in palliative care to be able to have serious illness conversations with those patients earlier on in their illness. I think people are not trained and they don't have the skills to have serious illness conversations, and they're worried about how that will impact their relationship with patients and families. The reality is these patients and families want to have these discussions. They want to feel prepared. So we need to train everyone to be able to feel comfortable and give them the skills and knowledge to be able to have these conversations. And I think that's the starting point. You have to recognize that this is important and begin conversations early to figure out how we can help them and prepare them for what's to come, and then have a values-based discussion on what matters to them besides living longer. So what are their goals? And then develop a care plan that matches that.
Fabulous, thank you. Yes, the gentleman at the far back.
Thank you. I'm wondering, I still don't understand if there's an interface between palliative care and MAID, or are the two incompatible?
I would,
Yeah,
so
you
MAID
explain
is,
what MAID is, yeah.
MAID is medical assistance in dying, so, which has become legal quite recently in Canada, and is legal in some other countries around the world as well, notably Belgium, and the Netherlands, yeah, and some states and the United States. So MAID is not the same thing as palliative care, is one important distinction. It has brought palliative care into sharper relief, I think, and which I think is important. So what our focus is on in palliative care is making sure that people live as well as possible, as long as possible, really. So, and MAID is a separate procedure that is performed on some people at their own, through their own will, but is not a part of palliative care. We actually have two separate teams at the University Health Network, a palliative care team and a medical assistance in dying team. And if someone requests medical assistance in dying, then they are assessed by 2 different people from the medical assistance in dying team. Of course, we still continue to follow patients who request MAID, but we do not actually ourselves perform MAID. So it's not incompatible, but they're two separate things, and we continue to follow the patient and treat their various problems and difficulties and concerns, whether or not they receive MAID.
Just hang on a minute. I also want to say thank you. Thank you for offering to feed us, by the way. She came up and said she wondered what I was going to do. And I don't want to turn this into a discussion of the ethics and performance of medical assistance in dying. That's a different discussion with a different group. So I want to see if there's other questions. Did you have a question different than that, sir?
Thank you. I have a 20-year-old question to ask. My late wife was struggling with multiple myeloma. There didn't seem to be any form of medication to relieve the pain. And this struggle went on for 3.5 years. And the last thing that we used were fentanyl patches, which covered half her back because there was studies that were strong enough. Have you come any further with dealing with the pain for that kind of illness in the last 20 years?
Was she receiving palliative care or from a palliative care specialist team? What's that? What's that, sorry?
No.
There's no such thing. Yes, so we have come further in treating pain. We treat pain through many different ways. Fentanyl patches are not our first choice usually in treating. That was the last choice. Yeah, and I'm sure she was through many things. But so we are specialists in pain management, is I guess all I can say. Opioids are still our mainstay of treating pain, but there are many other medications and also procedures that we use for pain treatment as well, along with our anesthesiology group or intervention oncology groups. So there are many different ways to treat pain that are different from 20 years ago, fortunately.
My question is advanced Parkinson, for a patient with advanced Parkinson, would be needing palliative care or can avail of the help of the palliative care?
Thank you. Ebru, why don't you take a look?
For sure, yes. That's really the simplest answer. I mean, anybody who is suffering from a life-limiting illness, regardless of what that illness is, if it's affecting them in any way, whether it be physical symptoms, social issues, psychosocial symptoms, anything that makes it difficult for them to continue to live in a way that they're accustomed to living in terms of affecting their quality of life, and would benefit from a palliative approach to care, then yes, the answer is yes, always. Unfortunately, there still isn't the kind of wealth and breadth of palliative care services. They still don't exist in the way that we would like them to be. So, services are very patchy. They're patchy across the city, they're patchy across the province, they're patchy across the country. But our goal and our hope and our wish is that in 10 years, 20 years' time, that this will no longer be a discussion point, that anybody who has a life-limiting illness, regardless of their underlying diagnosis, their age, where they live, or their prognosis, will have access to both palliative care provided by their normal hospital or community teams, as well as specialist palliative care teams when needed.
Sir, we'll get you a microphone.
This really falls on Dr. Keogh's comments, but it was one I was thinking of beforehand. My concern is the supply side of these resources. It seems to me there's 2 issues that I see, and I'd appreciate your comment on it. First of all, the availability of palliative care in our general public health system in Ontario, let alone Canada, is very patchy. And even hospitals that provide some palliative care resources are thin, not well trained, and very, very difficult to get access to. Frequently you have to really advocate for them because they don't really come and walk into your room and offer to help, as Warren said he does. So I would like to hear your comment on terms of where the healthcare profession is going in terms of trying to direct public policy to increase the resources, because we need a significant increase in resources if we are going to make this available to everybody. Right now it's available to very few. And the second part of that is if you're going to increase resources in institutional care, I think we're all familiar with the issues of long-term care versus chronic acute care. And from everything I've read, palliative care is as useful or even more useful in a home environment than it is in an institutional environment. And if we can't even staff our institutions, am I correct in thinking that home-provided palliative care is a really good, cost-efficient, and efficacy way to treat the problem? And where are we in terms of trying to develop the resources for that part of palliative care delivery?
Thanks. There's two interesting questions.
Two questions. Shall I attempt the first one?
That's right. Are you running for office by any chance? You have my vote. I just want you to know that.
Your first...
So yeah, Ebru, why don't you answer the question about provincial resources?
Yeah.
And I'm going to ask Warren or Camilla to talk about home care issues as well.
Absolutely.
Those are two good questions.
Your
Ebru,
first question is really, really timely because
hold the microphone closer because...
about 6 months ago, the government, so the federal government, released a document outlining the framework for palliative care across Canada. So they've already outlined this framework and they're in the stage of implementing action phase at the moment. And so as specialists in the field, we're doing whatever we can to advocate. So we're at the table with the federal government, and we're hoping that this would lead to significant changes in resources when it comes to clinical care for patients and their families, regardless of where they are. So regardless of where that patient happens to be, home versus long-term care versus acute care, as well as having standards for education levels, like clinical abilities for different clinicians who practice palliative care. In the past, anybody who wanted to could call themselves a palliative care expert. That is changing. So having some accountability built in to the system for not just individuals, but also health authorities. And then at the same time, I think along with this, there'll be an increased collaboration, not just within cities, but provincially as well as nationally, because previously everything's been a grassroots sort of movement, but things are starting to gain traction with the collaboration. And again, very recently, a local MPP from Hamilton is putting forward a private bill to try and essentially advocate for a structure for palliative care for children in Ontario as well. So I think things definitely are going to change in the next few years, and we're going to do whatever we can to advocate. I sit on the board of the Society of Palliative Care Physicians, so I'm really hoping that that's going to be one way to make sure that we're constantly advocating, working with the government, working with health authorities, and with patients and their families to make changes, put in improvements, and basically move forward, because that's been lacking and so desperate in need for so long now.
Thank you, Ebru. And just let's get a comment from, would you like to, Warren, comment on home palliative care and what that has to offer and what you think the role might be?
Yeah, so to your point, it's really lacking. It depends where you live. The first thing I do when I see a patient is I look up their postal code, and that's a shame, because if you fall in a certain region, you get great access, and if you fall in another region, you don't get great access. So we need more providers. And as Ebru said earlier, we don't have government funding to train the number of specialists that we need. So the idea of primary palliative care came about, that we should make sure that every single clinician is trained to provide basic symptom management so that someone can die at home if that's what they wish for. So that every single clinician can have a basic conversation to elicit what a person values in life, to make sure that their care is directed in such a way that it helps them get what they want in life. And so what we're doing here, thinking of new ways that we can do this, we need to imagine them, we need to get funding to pilot them, we need to evaluate them, and then we need to disseminate knowledge. And Camilla is a world-renowned researcher and is leading the way with that. I'm not as smart, and I don't do research per se.
Why
but
did we hire you? I don't know.
One thing that we've thought of and that we're piloting this year is we're having a family doctor come and spend 3 months with us part-time. Because we know most people who are already practicing are not going to come back and take a year off of work to be able to get these needed skills. So one of my interests is, what is a new model of teaching that we can do whereby someone can come and get the minimum competencies met so that we can give them a stamp of approval to go out in the world and practice in the community. And I think we're fortunate at UHN to have a primary care program at Toronto Western, and I'm partnering with them to try and imagine what these models can look like, train these folks up, be a leader in that, and then disseminate that more broadly.
It's a fabulous answer. Any questions from this quarter here? This woman, this young lady.
Hello. My question is about quality of life you keep speaking of, and I'm just wondering how important therapeutic recreation is to what you are doing, and if it is offered.
And
No,
you've been kind enough also to come up at the beginning and tell us that's your field, which is good. You probably can teach us about it. But let's see.
I went to therapeutic. I did therapeutic.
Thank you, though. But let's see if you have Camilla, do you have a
So
comment?
certainly, in terms of quality of life, our basic stance is that it's not just physical, but that we also treat emotional care. So we have psychologists and psychiatrists, and we as well do counseling for people to meet their emotional needs. And also their social needs and their spiritual needs. In terms of exactly therapeutic recreation, we have many different specialists on our team. We don't have a therapeutic recreation specialist. We do have psychologists, psychiatrists, social workers, physiotherapists, occupational therapists, and music therapists, art therapists. So I think some of that probably overlaps a little bit with therapeutic recreation.
Thank you. We have a question here.
Yes, at Toronto General, we started a Chinese hepatitis B peer support group. Is it possible, or is there one peer support group where doctors or specialists come and have occasional, let's say once every quarter or monthly, and then share the information where the patients and their families could come in and share their experiences?
An interesting point.
I think that's a great idea. We've done patient engagement sessions in other areas, particularly in our lung transplant patients, where we go in and we get a group together to try and bust some myths and answer any questions that they might be having in a very kind of supportive environment. And I'd be very happy to connect with you to see if we can't figure that out for your kind of group that you're thinking of too. I think it's a great idea. Thank you.
Yes, this gentleman here. Thank you. Good. See, everything comes to those who are patient. Exactly. Thank you. Sir.
Patient of a different kind. That's what patient of a different kind.
Patient, exactly. Very clever. Thank you. I get it.
Good afternoon. My name is Srini. My question is, how can anyone, either a patient or the family member, get the palliative care wherever they are being treated? If they are in an institution like where Warren is visiting, it seems to be easier. If some other place, either at home or in some other place, how can they seek or how can get the palliative care?
Is there any access, essentially? What's the access issue? I know it's a dream come true sort of thing.
Yeah, it's a really, really good question, and there's no simple answer, simply because, honestly, it's very dependent on the postal code, and we memorize what certain groups provide, and it all changes because the funding's changed or the resources have changed, so from 1 month to the next, things vary. They're still very fluid. But certainly, we do our best to connect with our community partners, including family doctors. So I think family doctors are a great place to start, first of all. They usually are pretty good at having a clear idea of what's available in their local area. And most of them, particularly in our city, know where various palliative care groups are. And if you're an inpatient at any of the units at University Health Network, then the way to do it is to approach the healthcare team that's looking after you or your loved one, and then they can get in touch with one of us.
Thank you. This young woman here.
Even though if somebody is not a patient of UHN unit, can they get referred to this place? How to get the patient, the family doctor, can they refer to whoever is necessary to get the care? Instead of going there to provide the service there, they can move to the whatever.
I was going to take that one on myself to say that that would be certainly a marvelous and worthy thing. You should just come to our emergency department some afternoon and see the 37 people in beds waiting to be taken upstairs and that sort of thing. The lineup here is immense, and it's an issue. If we have time, I'm going to ask Warren to think about telling us about his different experience at two of the world's wealthiest institutions, the Massachusetts General Hospital and the Mount Sinai Hospital in New York, compared to the hospitals down the street in Boston and New York. You might think about that one for a minute. But I have a woman who has a question right here.
Thank you. I wonder if you could tell us how many palliative care units there are in Toronto?
That's a good question. Does anybody know the answer to the question, how many palliative care units there are?
I think there are about 10. I don't know the answer exactly, but there's 2 hospices that are opening up in the next few months, but I think roughly 10.
Thank you.
There's a woman way at the back there, way at the back. I can barely see you.
Thank you. My friend had been diagnosed with terminal cancer, and she went around to different palliative care departments, and she got really scared because she saw some, people, screaming and sprawled, and nurses not really. They were so busy helping other people that they'd have to be waiting for long periods of time to get care, and she freaked out. And I just was curious about the environment that you have. Have you structured your environment to have a kind of a very nice, welcoming, kind of warm atmosphere, or is it still kind of institutionalized?
When I was in clinics at Princess Margaret, one of my patients that I had looked after for a long time had pain that was really difficult to control in the clinic setting. So I asked her to come in and be admitted in our palliative care unit. So we talked about what it would look like and who she would meet, what the care would be like, and then she got admitted. And then when I was rounding on her during the admission, at one point she said, "Well, you never told me it was going to look like this." And I said, "Well, what did you think it was going to look like?" And she said, "Well, I thought there was going to be black chandeliers and black curtains everywhere." But it just looked like a boring unit with lots of light streaming in, a beautiful, clean nursing station with very happy, cheerful nurses, occupational therapists, physiotherapists, social workers. And so what she had imagined in her mind was nothing, not even close to the reality.
Warren, what was the care like at Mass General in Mount Sinai, New York, compared to elsewhere?
So I will say that I feel very fortunate that I'm able to practice medicine in Canada. I feel like I can give my patients what they need here, more so than when I was in the States, because I can give it to everybody. And we partner with Kensington Hospice just down the street here. So to answer your question also, hardwood floors, there's a chef every day, music playing, it's a beautiful setting. In the States where I was, they have, I think, more money to make these places look nicer. They may be better staffed. You know, in New York City, they have a regular emergency department at Sinai. Then they have a geriatrics emergency department where the tiles on the ceiling are cutouts with stained glass looking like the sky to decrease delirium and confusion for people who don't know where they are. So it looks more like a natural setting. It's quieter. So if someone had palliative care needs, they would often come directly through that part of the separate emergency department, and then get ushered up to our palliative care unit with big windows that overlook Central Park, where the nursing ratios were much kinder to meet the needs of patients who are quite sick. Having said that, that care doesn't get provided to everybody. And again, what we can do here is get high quality palliative care to everyone within our walls, and we need to work hard to get it outside of our four walls as well.
So I would agree with everything everyone has said. I think a lot of the questions that everyone is asking are about quality of palliative care and access to palliative care. And I think there is a difference in the kind of palliative care you receive depending on where you are. We're very lucky here at the University Health Network and at the Toronto General and Western Hospitals to have an excellent palliative care team that sees patients in the outpatient setting as well as in the inpatient setting. So I think we're very fortunate in terms of the care that we get here. For those of you who are thinking about palliative care for yourself or for someone else, I would just encourage you to think about it early. Because the earlier you think about it, the more you can sort of look around and figure out what hospices. So hospices are freestanding locations that are not inside a hospital where you can get palliative care, whereas palliative care units are inside a hospital. And there's different environments that suit different kinds of people. So if you think of those things early and talk about that with your physicians or with your healthcare team, then you end up having more choices as time goes on.
Yes. We'll get you a microphone.
Thank you. Good afternoon. My question is simple. I've been involved in a number of palliative situations with family members and friends, and some have been great, some have been disastrous, and some have been learning experiences. Having said that, the reality is there's absolutely no help and training for the advocate caregiver person who's on site all the time with a loved one. What are you going to do with that for us who are running out of steam, running out of energy, on sort of responsive phone calls, that kind of thing? It's palliative care is brilliant, but the caregivers are struggling. They're really struggling with no place to go and no place to say, I need help too. And I'd really like to know what's going on in that energy.
So we actually, as part of a qualitative study where we interviewed caregivers about their experiences at the end of life, we ended up titling it actually, I didn't want to be in charge, but yet I was. And I think many of you can probably relate to that the caregiver ends up being in charge of looking after a very ill person without really necessary resources to do that. What we are trying to do is develop caregiver clinics. Again, all of these things need resources, but ultimately I think that's what we need to do, is to have training specifically for caregivers who want to provide care at home, but also provide better home care. And I think this is where all of you can also be advocates. And I think palliative care sometimes doesn't receive the attention that more flashy disciplines with lots of fancy machines and expensive drugs receive. We're sort of a more low-tech kind of a specialty. And we don't get as much press, I guess, as we maybe should. So I would encourage you to call your local MP and advocate for palliative care.
We have a gentleman over in the far end.
If my wife were here, or could be here, I should say, she would be the one asking a question. But I have to speak because I lost her just over a year ago after she had 3 weeks of palliative care. Everything went well during that time, but she died. And my concern was that although she was part of the network as a patient, it seemed as though information had not been given out to other parties in the network. So I got a question coming about a month after her passing from her family doctor, and about 5 months after that, reminding her that there was an appointment she had to keep. My question is there some way in which the network can communicate among its members as to the outcome of palliative care and what the current situation is? Thank you.
Good question, systems question.
Yeah, I'm very
Camilla?
sorry to hear that, and it must have been extremely difficult for you to get that kind of a message. And that does unfortunately happen, and we don't have the kind of communication systems in Ontario or even in Toronto among hospitals that are necessary for that. We're starting to begin to have that through Connecting Ontario. But there's still a lot of things that get lost in the tracks, unfortunately. But I'm very sorry to hear about that.
I just want to add to say we're doing what we can as specialists in this area to try and kind of whenever we come up with a new program or a new system or a new training tool, that we're doing our best to make sure that it's something that we can get together with all our colleagues across the city, if not the province. For example, Warren mentioned a certain type of teaching tool, the serious illness, vital talks, conversation guide. So this is becoming more and more familiar and popular as a teaching tool in North America. So this is one of the reasons why we want to use it in our institution, because then lots of people are familiar with it. It's something that's well known, and it aids and prevents those kind of silos or prevents the perpetuation of those silos. And we're doing our best when we come up with a protocol or a policy that we engage our other colleagues to say, hey, we've come up with this. Do you want to see if you can use this in your institution as well? And then again, another way to break down some of those kind of silos.
Last question, that gentleman in the back.
Thanks. I'm a retired nurse on Toronto Island, very happy to be relieved of sandbagging this afternoon. But I must say, and we know that we've got more to come, we discovered by accident that of all the census tracts in Canada, we are of the 2% oldest in our simple community of 700. But I must say, we have been absolutely blessed between CCAC, LINS, or whatever today's name for it. We've been absolutely blessed, and by palliative care. I've been involved, drawn into at least 8 cases in the last 6 years. And I do agree, first of all, that this is all at home. First of all, it does require a very strong partner, no doubt, to deal with the 24-hour care bit, in spite of all the help. And my only the single failing was in the first 2 cases, my buddy and 200-pound, 80-year-old Peter both had lymphoma, both had the comment about, well, I don't really have pain, only discomfort. And they weren't given anything. And the day after...
Do you have a question that you wanted to ask?
I just want to say,
yeah.
Be sure that the patients are given hydromorphone or something just in, that they have the prescription just in case.
Thank you. Thank you for sharing that experience. Thanks for the good news about the islands. We're going to conclude the session by, first of all, thanking all of you for coming and showing interest in this emerging field, which you have heard today, and I think so many of you have commented, realize the critical importance of this to the quality of life that we offer to our citizens and our patients. This emerging area, the shortage of excellent resources, the need for us to continue the education and the research and the patient care, and how blessed we are here at UHN to have this outstanding team of experts looking after us. Thank you very much, everybody.
I just wanted to take a quick second and thank the wonderful Dr. Baker, Doctors Camilla Zimmermann and Lewin for participating this afternoon, and for all of you for attending. We really appreciate your interest and your support, and we'll look forward to seeing you in the fall. Thank you very much.